Let's start the heart anatomy. First of all, we have this left atrium, which is the most posterior part of the heart. Remember, we are looking from below. This is the left side of the heart, and this is the right side of the heart. So, left atrium is the most posterior part of the heart, and enlargement of the left atrium will compress the esophagus, and usually uh, left atrium enlargement is occurs in mitral stenosis. Whenever you stenose the mitral valve, there will be a backward flow of blood that will enlarge the left atrium. Enlargement of the left atrium will push the esophagus, and that will lead to the dysphagia, difficulty in swallowing. So, um, also, it will irritate, or you can say compress, the left recurrent laryngeal nerve, which is a branch of the vagus nerve, and that will lead to origins of the voice. So we call this condition as Otter syndrome. Now, if you look at the RV, it's the most anterior part of the heart, and most of the like it's most commonly injured in trauma cases because it's the most anterior part. So when someone stab a person on the sternal area anteriorly, so commonly injured is the RV. Moving towards the left ventricle, it's about like two-thirds, and RV is about one-third of the inferior diaphragmatic cardiac surfaces. Most of the inferior surface of the heart, it's formed by the LV. Okay, that's two-thirds of the inferior surface is formed by the LV. One-third is formed by the RV, while anterior surface mostly is formed by the right ventricle. So, if you look at this X-ray, important thing is to identify the structure. Like there is a aortic knob here, not clearly visible, but I hope you will know that this knob. Okay, this is aortic knob. This is the pulmonary arteries are here, and obviously the left atrium, then the left ventricle, then the right atrium, the right ventricle, inferior vena cava is here, azygos vein, and superior vena cava. So remember, the important thing in this X-ray is that the middle lobe of the lung is near to the right right heart border. Uh, you can see here that the right border of the heart is the right border, and it's common, like it's formed by this right atrium, and near this right border we have this middle lobe of the lung. So whenever there is some consolidation in the right middle lobe, it can obscure the X-ray silhouette of the right heart border. Just remember, okay. Now, if you look at this pericardium, so it's basically consists of three layers. First is the fibrous, then is the parietal, and then is the EP. Uh, in between the parietal and the EP is the pericardial space, and contain almost 15 ml of fluid, and it can the fluid can the amount, or you can say the range is 15 to 50 ml. Uh, this is the area where in cardiac tamponade the blood accumulate here. Uh, Also, another thing is that in the pericardium is basically innervated by the phrenic nerve, and pericarditis. The the refer plane of the pericarditis is towards the neck, or both shoulder or arms. So it's basically a refer plane, neck, shoulder, and arms. If you look at this epicardium, it's the side of the coronary vasculatures. Okay, it receives largest blood flow, the epicardium, and the subendocardium receives a smallest amount of blood. Now, the anatomy, or you can say the coronary blood supply, is high yield, and we must know that the LAD and its branches basically supplies the two-thirds of the interventricular septum and anterolateral papillary muscles and the anterior surface of the left ventricle. Most commonly, the occluded vessel is the left anterior descending artery. We know that anteriorly the left ventricle, anterior and lateral blood flow of the LV, left ventricle, is by the left anterior descending artery and the left circumflex artery. Now, the anterior lateral papillary muscle, we have two papillary muscle, anterior lateral, posterior medial. The anterior lateral papillary muscle, as the name indicates, the anterior wall and the lateral wall. So it is supplied by the LAD and circumflex. So there is dual blood supply to the anterior lateral papillary muscle. In contrast to that, the posterior medial papillary muscle is supplied by only either PDA or RCA. So if there is anterolateral papillary, if there is left anterior descending artery occlusion, the supply to the anterior lateral papillary muscle will be from the left circumflex. But in case of the PDA occlusion, then there will be a infarction of the posterior medial muscles because there is only single blood supply. This point is important. Another is that, as the name indicates, left anterior descending arteries, so definitely it's the anterior, like 2/3 of the interventricular septum and the anterior wall of the heart beside the anterior lateral papillary muscle. The PDA is supplying the 1/3 of the interventricular septum and the posterior and inferior surface of the ventricle. So posterior 2/3 of the ventricular wall and the posterior medial papillary muscle beside this 1/3 of the interventricular septum. RCA supplies the AV node, the SA node, and in fact may cause like nodal dysfunction. Like it may cause, let's say, if we say that RCA is supplying the AV node, the SA node, and we occlude the RCA, then it will lead to the rhythm problem of the rate problem of the heart. So person become bradycardic or goes into a heart block. The right acute marginal arteries supplies the RV, right ventricle. So basically the marginal branches are from the RCA, nodal artery, the AV nodal artery, the right marginal artery. These are the branches of the right coronary artery. So the right coronary artery basically supply the AV node, SA node, and the right ventricle to the marginal artery. Next thing is the dominance. So we have the right dominant circulation or the left dominant circulation. To know this, remember, the important rule is that if the PDA arises from the right coronary artery, which in the 85% of the case, then we call it right dominant. In 10% of cases, PDA is arises from the left circumflex and we call it left dominant. But in 5% cases, it's arising from both the RCA and the PDA and the left circumflex, and we call it codominance. Now, coronary blood flow to left ventricle and the interventricular septum peaks in early diastole. Very important point. Remember, whenever most of the left ventricle receives the blood supply during diastole, and the reason behind this is that the pressure in diastole in the left ventricle is only 10 millimeter of mercury. That's why during diastole the blood flow to the left ventricle is more. During systole, the pressure within the ventricle is high, so it will compress the vasculature within the myocardium, and that will lead to decreased blood flow. Within the coronary sinus, so the coronary sinus basically runs in the AV group, and it's finally drains into the right atrium, and it contains the most deoxygenated blood of the heart. Okay. Now moving towards the myocardial perfusion, remember we said that during diastole the heart, the LV received most of its blood supply, and we also know the reason. Also remember that if you decrease the coronary perfusion pressure, if you decrease the coronary blood flow, that will lead to the release of the nitric oxide and the adenosine, and that will increase the blood flow to the within the coronaries and to the heart. So this is basically the auto-regulation mechanism of the heart, that between the 60 to 140 millimeter of mercury of the blood pressure, the heart can uh, it auto regulates blood flow. If you decrease the blood flow, it will release the nitric oxide and adenosine. If you increase the blood flow, it will decrease the nitric oxide and the adenosine flow. So these are the 2 points regarding the anatomy of the heart that I would like to share. Other than that, this chart is very important. The characteristic of the left and right ventricle. Remember, the mass of the left ventricle is high. The resting oxygen extraction of the left ventricle is high. Whenever you increase the muscle mass, you are increasing the oxygen extraction. The more oxygen is required. The blood flow to the left ventricle is more during the diastole, and it occurs only in diastole. Compared to that, the right ventricle muscle mass is low, resting oxygen extraction is low, coronary perfusion occurs in both in the systole and diastole because it's a low pressure chamber. So throughout the cardiac cycle, the right ventricle receives blood supply. Collateral circulation more developed in the right ventricle compared to the left ventricle. Whenever if someone gets this myocardial infarction, that will lead to the collateral circulation. So it's more developed in the right RV compared to the LV. Ischemic preconditioning. Remember, ischemic preconditioning is a condition in which if you decrease the blood flow to the myocardium, then this phenomena will start occurring. And ischemic precondition is more in the right side compared to the left side of the heart. So overall, this diagram is about this autoregulation of the heart. Remember, this coronary blood flow here is low, and the low coronary blood flow, nitric oxide release, adenosine release, the blood flow is increased. Now, in case when the coronary blood flow is high, then the nitric oxide and adenosine both like the amount of these two hormones will decrease, and that will lead to decreased blood flow. Moving towards the valves. So in case of the valvular anatomy, you can see here there's the mitral valve. So in the mitral valve, we have basically two cusps, anterior cusps and posterior cusp. And we have two papillary muscles, the anterolateral papillary muscle, posterior medial papillary muscles. We discussed the blood supply of these muscles. Just remember, in case of the inferior infarction, can lead to rupture of the posterior medial papillary muscle due to single blood supply either from the PDA or from the RCA, and that will lead to severe mitral regurgitation or acute heart failure. This was about the anatomy of the heart, and in the next section we will be discussing the physiology of the